So Soham sir, after you
Yeah.
allow me to present them.
Uh, Ajay, these are your slides. Okay.
Yes.
Uh, okay. Let me. So once you like you have a reasonable number of attendees have joined in, just tell me, and then I can start. I think maybe it is if possible, just do include all.
Yeah, yes, sir. We opened that, so now all are joining in the same room. Yes.
Okay. Should I start now?
Yeah.
Or wait a few minutes. I'll wait for 30 seconds and then I'll start.
This Brahma Vishnu Mahesh is very unique.
Oh, is it? I have not seen only this name.
Sir, you
Sure,
are
it is
Brahma.
making me Narad. And you all three are the Brahma Vishnu.
Brahma, sir. Paul, sir, is Brahma.
Has Neeraj joined?
Yeah, I'm there.
There, Neeraj.
Yes, Mahesh.
Yes, yes. Okay. So good evening all. Welcome to this another monthly edition of this session, Controversies to Consensus in Neurology. Here we initially debate and then try to reach on a consensus on specific management issues in different neuro disorders, and we are focusing mainly on three things: epilepsy, movement disorders, and headache. So this time we are taking up movement disorders and what not, and then the most common of all, Parkinson disease. So Parkinson disease is a disorder which affects a significant number of patients, especially in the elderly group, but not just them, even the others too. And what we all observe is that in India, when a patient is diagnosed with Parkinson's disease, they are started on a triaxiphenidil and levodopa. So the debate is that do we need to give triaxiphenidil in all patients with Parkinson's disease? And like if we see, look at the Western countries, what they do is they generally do not give triaxiphenidil. But somehow in India, most of the patients are on triaxiphenidil. So the shaking palsy, like I thought, let us shake the status quo where lot of doctors keep writing triaxiphenidil, sometimes even before levodopa is started in patient Parkinson's disease. So like, what is being done? Is it correct? And then there are few, and then you are very vocal that you should always avoid triaxiphenidil in patients with Parkinson's disease. In fact, people have done papers, even studies from India, like Dr. Rupa, who is one of the proponents of not to use triaxiphenidil. She has done a paper in review study, which she'll also highlight on why not to use. And so we have Dr. Suvarit and then Dr. Rupa are speaking for and against the use of triaxiphenidil. And after that, we'll have Dr. Pal, Dr. Pandey, and Dr. Neeraj give their views on what they feel and what should, and they will help us in guiding us from the controversies to what should be the consensus of practice in our country. So, like before beginning, let us see what the audience feel. Can I have the poll question to see what the current members of the audience feel? Can we have the poll? So like this is like the whole debate would not just run on this scenario, but like just to begin the discussion, the question is in a patient with Parkinson disease of around 50 years of age, normal cognition, no prostate disease. Do you believe that triaxin should be used in treatment? So the options are yes, because it helps me in better control of tremor compared to levodopa alone. Second is no, because it doesn't have any added benefits. Rather, it will lead to issues in the long term. And third is I'm not sure. I'd like to know more by listening to the speakers today. You can begin the poll now. So the panelists will not be able to give their vote. So Surit and Rupam, you will not be able to vote in for your. own answer. Maybe in about 15 seconds, we can close the poll and see the results. Can we see the results? Yes, so see, the 60% of audience believe that in this patient, trihexyphenidyl should be started because people feel that levodopa alone will not help improvement. And actually, there are 15% who are not sure that is good, and 20%, 25%, one-fourth feel that it should not be given. So I think we have a pretty mixed bag, but more than half believe that trihexyphenidyl should be used. So with that, I think Suvarit, you have the lead at present. I think a bit of your work is easy because half of the audience believes that it should be used. So let's have Suvarit, who has, like in his first slide, made me Narad. I'm not Narad. Here, I'm not trying to stir a controversy. I'm rather more like this is a common practice that we face. So Suvarit, I welcome you, and the stage is all yours. You can begin the discussion.
This is my first slide, and sorry, Soham sir, I had to make you Narad in my first slide because one fine day 2 months ago, you asked me to stand for trihexyphenidyl in Parkinson's disease. And I'll be very honest, I rarely use this drug. And in most patients that I get, if they are using this drug, I try to get them off this drug and try some other strategies. So I have Professor Pal, Professor Pandey, Professor Kumar standing as Brahma, Vishnu, and Mahesh, who will help us guide and reach a consensus whether to use this drug, when to use, when not to use. And in fact, I tried to reach a truce with Dr. Rupa Rajan, and I told her that you are going with the tide, I am going against the tide. So
no, Suvarit, actually, audience is with you. More than half of the audience feel that it should be used.
You'll see I have very less to defend. So trihexyphenidyl is an anticholinergic drug, but the mechanism, how it works in Parkinson's disease is not clearly known. It possibly ameliorates the cholinergic hypersensitivity in the striatum, which occurs as a result of dopamine depletion. And some anticholinergic drugs like benztropine possibly inhibits the presynaptic reuptake of dopamine, thus increasing the availability of dopamine in the striatum. So these are some proposed mechanisms of action of anticholinergic drugs like trihexyphenidyl. So this is a case scenario I'd like to put forward. A 37-year-old poor lady with Parkinson's disease is symptomatic for 2 years with right hand and right foot tremor, right shoulder stiffness, right-sided slowness, and she complains that right foot twists while walking. And the current issue is that she has bothersome right upper limb dyskinesia with such a low dose of levodopa, just half a tablet of levodopa carbidopa 100 by 25. She has bothersome dyskinesia of right upper limb. And then we have a lot of treatment options. MAO-B inhibitors, COMT inhibitors, dopamine receptor agonists, amantadine, anticholinergics, and the last one, which is not available in India as of now. So what would you do? Will you omit levodopa and try dopamine agonists like pramipexole or ropinol? Keep levodopa, add a dopamine agonist, keep levodopa, add amantadine, or omit levodopa altogether and try amantadine plus anticholinergic. So we can try all the options for the patient, but we know that PD is a heterogeneous disorder. One single option may not work for all. For example, you may omit levodopa and try dopamine agonists, but some patients may not tolerate dopamine agonists or may have high risk for side effects from dopamine agonists. Side effects mainly impulse control disorders. Keeping levodopa and adding amantadine is a good option, but at some point she would require high dose of levodopa, and we know that increasing the dose of levodopa beyond a certain level in such a young patient increases the risk of dyskinesia. She already has a dyskinesia, and so she won't be able to tolerate higher dose of levodopa. She is a poor lady, and she therefore cannot afford advanced treatment options like deep brain stimulation surgery. And there's also one option where you could just try amantadine plus anticholinergic and omit levodopa altogether, or keep it as a reserve drug later on. So anticholinergic for motor symptoms. So Professor Pal did a very good study recently, and he showed whether anticholinergic drug alone improves motor symptoms of PD. We know that it improves tremor as the major symptom of Parkinson's disease, but it also has some effects on bradykinesia, rigidity, and axial symptoms, but not as marked as levodopa. So if you are pitching against levodopa, then there's and one can guess that, of course, levodopa is the better drug, which improves all the symptoms of Parkinson's disease, including tremor, rigidity, and bradykinesia in a young patient. Again, the current thinking is that you do not deprive them of a good quality of life, and you can start levodopa early on. And if not levodopa, you can also start dopamine receptor agonists. But this is the slide just to show that anticholinergic drug has effect on all the motor symptoms of Parkinson's disease. It has synergistic action with levodopa, which means that if the patient is on a stable dose of levodopa and you don't want to increase the levodopa for fear of dyskinesia, then adding an anticholinergic drug improves motor symptoms of Parkinson's disease, including tremor, rigidity, and bradykinesia. But the side effect profile of the drug is not so good. Particularly dyskinesia may also be aggravated by addition of anticholinergic drug, and there are certain non-motor side effects of anticholinergic drug, which Dr. Rupa Rajan will tell, I'm sure. It is also synergistic with amantadine. This is a very old study where an anticholinergic drug was used alone or in combination with amantadine, and the patients were compared to levodopa, and it was shown that the total disability reduction achieved by anticholinergic and amantadine combination is comparable to that of levodopa alone. So anticholinergics do work. And also, it's not easy to withdraw anticholinergic drugs because abrupt withdrawal may cause worsening of all Parkinsonian symptoms. So I have had patients, some patients, who, when I try to withdraw anticholinergic drug, for example, trihexyphenidyl, they don't tolerate at all. They come back to me saying that, oh, this drug was working very nicely for me. Why did you try to withdraw the drug? I want to go back to the same drug. So there are going to be some patients who are already on anticholinergic medications, but withdrawal may be a challenge. So this is a nice figure which shows that patients who had micrographia initially while not on anticholinergic, and then the handwriting improved a bit on addition of anticholinergic to levodopa, and then again anticholinergic was withdrawn, handwriting worsened, and then improved again on re-addition. So anticholinergic withdrawal may be a challenge in these patients, in some patients. And then, of course, we have this anticholinergic drug for amelioration of dystonia. And we know that early onset PD patients are more likely to present with dystonia than older onset PD patients, and response to levodopa does not always parallel that of the hypokinetic rigid features. It means that levodopa may improve dystonia, but there are going to be some patients who have a persistence of bothersome dystonia despite adjustment or increment in the dose of levodopa. In those patients, for example, patients who have Parkin mutation, who have dystonia, in those patients, addition of anticholinergic drugs may ameliorate dystonia. So it has uses other than the classic motor symptoms of Parkinson's disease. So I'd like to end because I don't have much to defend. Dr. Rupa Rajan will be telling more about non-motor symptoms, when not to use trihexyphenidyl, or why not to use trihexyphenidyl at all. So it's important to know when to use trihexyphenidyl and when not to use trihexyphenidyl. So trihexyphenidyl can be an option for young PD patients, or patients who are cognitively okay, patients who do not tolerate higher doses of levodopa. They develop a lot of dyskinesias on higher dose of levodopa and cannot afford advanced treatment options. And those patients in whom you are considering dopamine agonists, but you follow them up and they have risks of, or they already have some bothersome side effects of dopamine agonists, like impulse control disorders. So this is my last slide. So I'd like to end my points for the use of trihexyphenidyl here.
Thank you, Dr. Suvarit. I think we can move ahead with what Dr. Rupa says, and then we can have one or two comments from each. After that, we'll have the poll again. And once the audience again changes their view or not, we'll see, and then we'll have expert views from our panel of experts. Dr. Rupa, you can begin. Thank you, Dr. Suvarit.
Thank you, Dr. Soham, for this opportunity to take part in this very important debate today. So when Dr. Soham told me about this debate, I was thinking that, I really respect my co-debater, Dr. Suvarit, who I thought had the really difficult task. So asking a movement disorder specialist to defend the use of trihexyphenidyl in Parkinson's disease it takes some effort to do. But now seeing the poll results, I see that I am probably the one who is going to have to swim against the tide. So definitely then this is an apt topic to have a discussion, if not a debate on. And without much further ado, I would like to take my position against the use of trihexyphenidyl in Parkinson's disease. So I will be arguing not for using trihexyphenidyl. I do not have any conflicts of interest related to this talk. So I will, in the next 15 to 20 minutes, I would like to take you through this topic under the following headings. First, we would see the scope of the problem of this use of trihexyphenidyl, or more in general, anticholinergics in Parkinson's disease. We will see some clinical scenarios to understand how it is in the clinic, and what difference using or not using this drug makes. Then we will talk a bit about the evidence from clinical studies, a little bit about the evidence from pathophysiological studies, and then we will try to wind up and understand whether we would like to use this drug in PD or not. So if you look at the data worldwide, this is a nice systematic review published in 2019 in the Journal of Parkinson's Disease. If you look at the use of anticholinergics in this left hand diagram, you can see that the anticholinergic prescription rates for Parkinson's disease are very low in developed nations such as the USA and Europe. It's about 5 to 6%. You can see it here. Compared to levodopa, where the usage rates in, for example, Sweden or other countries is like, somewhere about 50 to 60%. So anticholinergic prescription rates are very low in these nations, whereas it is kind of high in Asian countries, especially countries like India, Japan, and Singapore. In about 22 to 40% of PD patients are prescribed anticholinergics. And if you look longitudinally over the years from 1992 to 2012, overall, you can see that there is a decrease in the use of anticholinergics over the years as more effective and safer treatment options have come up for Parkinson's disease. You do not see that with levodopa. The usage is almost stable across the years. So if you look at the Indian scenario, so this graph I have sort of put together from AIMS in New Delhi and NIMHANS in South India. This were from two papers that we had published in 2017 and 2020. The NIMHANS cohort is a much larger cohort, and they are patients who have presented for the first time to NIMHANS, whereas our cohort is about 289 patients in this data. And these are some of the patients are already on follow-up. So, but you can see that about 80 to 90% of patients are on levodopa, and about 30 to 40% patients are on trihexyphenidyl. So this is reflects the same that was found in the systematic review, that more than 1/3 of PD patients in India are exposed to trihexyphenidyl use. And this is followed by, of course, dopamine agonists and amantadine. So let us look at the understanding the scope of this problem. Now let us look at what happens when you give trihexyphenidyl to patients. So this is a patient, a 56-year-old lady who had right upper limb rest tremors, slowness and stiffness for 1 year. She was diagnosed as Parkinson's disease and started on trihexyphenidyl 2 milligram thrice a day. The tremor improved, but she developed abnormal lip and jaw movements. So if you can see, this is very subtle. I'm sorry I could not get a better video, because this is such a common problem in the clinic. It is not something that we document very regularly. But if you can see those slight lip and perioral movements, sometimes this can be much more severe. So these are orolingual dyskinesias, which are likely induced by trihexyphenidyl. So the trihexyphenidyl-induced dyskinesias are usually oromandibular or lingual, and they can occur early in Parkinson's disease soon after the exposure to anticholinergics. It is not like the dyskinesias that develop later with levodopa therapy. And these dyskinesias are sometimes not associated with levodopa drug timing. So that means it can persist in off time also. And they usually resolve on withdrawing the drug. And you may see these dyskinesias not only in PD patients, in patients who are given trihexyphenidyl, for example, for dystonia. They may also develop these perioral movements. And how do we distinguish this from levodopa-induced dyskinesias? They occur slightly later in the course of Parkinson's disease, and they are predominantly limb dyskinesias, coriform movements in the limbs. And if you see these atypical perioral movements early, one thing to consider is whether they are trihexyphenidyl induced, and reducing them may improve them. If it does not, then these may be patients who are going to evolve into some atypical Parkinsonism like multiple system atrophy. So those are the least of the problems that trihexyphenidyl can cause. Let's look at this patient, 43-year-old male, who had, he's young, rest and postural tremors in both the upper limbs for 1 year. He was evaluated and started on levodopa and carbidopa, pramipexole, trihexyphenidyl, and rasagiline all at the same time. And 2 months later, he developed behavioral abnormalities, severe delusions of persecution, visual hallucinations, and which led to a consultation with a psychiatrist who stopped all the medications. And 2 weeks later, he had worsening motor symptoms, persistent hallucinations, severe depression with suicidal ideations. And then he was referred to us for evaluation of a suspected dementia with Lewy bodies. So this is in a very young patient, and this is an actual patient whom we had to admit because the diagnosis was not clear initially. So, and this gentleman on examination had a typical asymmetrical rest tremor with bradykinesia. On cognitive testing, there was no dementia, there was no myoclonus, no autonomic dysfunction or any cognitive fluctuations. And we gradually, we tapered the pramipexole, the trihexyphenidyl, and the rasagiline, and continued him only on levodopa and added some quetiapine, which we tapered over the next 6 months. And now at 4 years follow-up, he is doing very well. So what did trihexyphenidyl and perhaps pramipexole also, but the most likely culprit for hallucinations is usually trihexyphenidyl. So it has converted what was essentially a simple young onset Parkinson's disease into a DLB kind of phenotype. So that is drug-induced cognitive impairment and hallucinations. Now, this is another scenario, a 69-year-old male. He is little older. He has already had Parkinson's disease for the last 10 years, is having motor fluctuations and mild dyskinesias, already on levodopa, carbidopa, entacapone, and amantadine. And for these uncontrolled motor symptoms, recently trihexyphenidyl was added, 2 milligrams twice a day for bothersome tremors in the off time. And 4 months later, he develops cognitive impairment. And these is particularly for recent memory, and he's having trouble with calculations, managing his finances and business. So when this happens, say about 10 years into the illness, then one is worried whether, he is developing a PD, going into a PD dementia. But the first step in these patients is, again, to slowly taper off the trihexyphenidyl, and we watch for any worsening of motor symptoms, which can definitely happen if we suddenly abruptly stop it, and then we adjust or increase the levodopa dose accordingly. And just tapering of the trihexyphenidyl resulted in improvement of cognition to the baseline for this patient. So we saw a spectrum of 3 patients, one with orolingual dyskinesias, which is the least of the problems that trihexyphenidyl can cause. Second, with a very severe neuropsychiatric hallucinations, delusions syndrome. Third, with cognitive impairment, which mimicked a natural progression of Parkinson's disease. In all these 3 cases, removing the trihexyphenidyl resulted in improvement of symptoms. So if I am to talk to you about other problems with dihexyphenidyl, the expert panel can add on to this if I have missed some out, but dry mouth is a very common problem. Orolingual dyskinesia, as we very frequently see, constipation, urinary hesitancy and retention, especially in elderly males with prostate enlargement, glaucoma. Sometimes if we are not watchful for an increased IOP and we do not want, sometimes patients can end up in blindness from glaucoma, acute angle closure glaucoma. Hallucinations very commonly worsened by trihexyphenidyl. Cognitive impairment can be worsened. And last but not the least, axial symptoms, gait, freezing and falls can be brought about by exposure to anticholinergic drugs. So I would like to remind you that the motor symptoms, the tremor, slowness, stiffness, this is just the tip of the iceberg in a patient with Parkinson's disease. These are a host of non-motor and other symptoms which are under the, the surface like an iceberg, which also we have to consider when we start any medications for Parkinson's disease. So now I have my worthy opponent may ask you, may tell you that, I am just talking about cases. What is the evidence? This is just anecdotal reports. You don't need to believe me. But what is the evidence? So there is a lot of data on anticholinergic effects and anticholinergic burden in elderly and in Parkinson's disease. If we talk about general elderly, this is one of the studies, a large population-based study of 13,000 patients with Parkinson, with healthy participants over the age of 65 years. And in them, they found that the use of medication with definite anticholinergic effects, like our trihexyphenidyl, resulted in a 0.33 point greater decline in MMSE score compared to those who were not taking anticholinergics. More importantly, 2-year mortality was greater in patients who were taking definite anticholinergic drugs and possible anticholinergic drugs. So in general elderly population defined as more than 65 years old, great decline in MMSE and increases the mortality. What about the effect on cognition? So this is from PD patients. These are slightly older and one a newer study. If you look at these smaller studies, the first 2, where they gave trihexyphenidyl for 2 weeks, just an acute exposure resulted in executive dysfunction when tested using an executive dysfunction battery. And just anticholinergic monotherapy compared to levodopa monotherapy or no therapy impaired the cognitive shifting abilities. Again, this is a part of your executive network. And this is a recent study from a Polish cohort of 418 patients, which showed that higher anticholinergic burden was associated with PD dementia in this cohort as well. So effects on cognition are very much proven. And this is the review. This was from our case control study. But when we reviewed the literature as part of that study, we saw that there are definitely big studies. If you see the second study, which is 16,302 patients with Parkinson's disease, it was a retrospective audit of hospital administrative data. And those who had anticholinergic exposure were about 57%. And those with strong anticholinergic burden were more likely to be admitted with fractures, that means falls, delirium during the index admission, and to require more emergency visits or readmissions after discharge. Then there is another study, 235 patients. It's a prospective cross cohort study, which also looked at the anticholinergic burden, and they found that at 8 years, this was a longitudinal cohort, and at 8 years, those PD patients who received at least one drug with anticholinergic activity had higher cognitive decline than those who were not taking anticholinergic drugs. So this is strong data. The third study was our study that I will discuss a bit more in detail. So So this is our study. So you may argue that the other two, the 16,235 patients data is basically from elderly. So one argument that we hear again and again is that Indian PD patients are younger, which is true. Our patients are about a decade younger at the age of onset. And so because of their young age of onset and younger age in general, they may tolerate these anticholinergic drugs a little better. So to look at that, we looked at our data of about 289 patients with Parkinson's disease who were attending our clinic, and 68% were male, and the mean age of this population was about 57 years, and they had PD for about 6 years before the onset. So it's a relatively young, at least a decade and a half younger than the Western cohorts. And about 58% of these patients had an anticholinergic burden score of more than 3, which means a significant or a severe anticholinergic burden exposure. And this anticholinergic exposure was independently associated with cognitive impairment in this cohort, and also freezing of gait, which we assessed using the UPDRS, which may not be the best way of doing it, but both objective and patient-reported freezing of gait was more in patients who were exposed to anticholinergic drug. So we concluded that patients, of course, are exposed to significant anticholinergic burden from drugs prescribed for PD and other non-PD indications, and higher anticholinergic burden is associated with cognitive impairment and freezing of gait, even in younger patients with PD. So this is just to show you this heat map. The top panel, you can see the ACB score. As it goes from green to red, it's increasing ACB score, and you can see that cognitive impairment is more on the right hand, freezing of gait is more, and in both patient-reported as well as objective freezing of gait is more. So, and this was independently associated with these problems, even in our young cohort. And then that drives you to ask, what drives this anticholinergic burden? Is it drugs that we are prescribing for PD, or is it something like, something prescribed by the urologist or by the psychiatrist that is contributing to this burden? But if you see, most of these are medications which are prescribed by for PD indications. So especially the high risk medications are, almost all of them are for PD indication, meaning they are basically trihexyphenidyl. So now this is the clinical evidence. So you may want to know what does that mean? I mean, how does it happen? It is a drug that we know that causes good motor benefit, but what happens in the brain when you take trihexyphenidyl? So this is a beautiful paper from 20 years back, but this used the UK Brain Bank PD brains and looked at PD brains of the brains postmortem of patients who were not exposed to anticholinergics, which is this none, who were exposed to anticholinergic for a short duration, like less than 2 years, and who were exposed to anticholinergics for long durations, more than two years. And you can see this first graph shows the senile plaques, the Alzheimer-related, the senile plaques, and those were much more in the PD patients exposed to anticholinergic drugs chronically, significantly more. And the neurofibrillary tangles were also more in patients exposed to anticholinergic drugs. So this is hardcore pathological evidence that exposure to anticholinergics in PD results in more deposition of neurofibrillary tangles, senile plaques, amyloid plaques, and more. This is why probably they develop cognitive impairment and dementia. So this is pathological evidence. So that brings us, after hearing all these horror stories, why should we use this drug? What is the utility? So Dr. Subodhit already showed you this graph, that the utility is that some selected motor symptoms may improve with trihexyphenidyl. But if you look very closely at this graph, the first graph shows the UPDRS scores in off and in after giving trihexyphenidyl and after giving levodopa. In all of the three types of UPDRS scores, like the total score, the tremor score, the bradykinesia score, rigidity score, and the axial score, levodopa definitely results in good improvement in all of these. Trihexyphenidyl also results in some improvement, but if you look here at the percentage improvement, this first block of graphs is with levodopa, and the second block of 5 graphs is with the trihexyphenidyl. So for tremor, the improvement is 67% with the levodopa and 53% with the trihexyphenidyl. For bradykinesia, the improvement is 65% with the levodopa and only 30% with the trihexyphenidyl. For rigidity, it is 67% and 20% with trihexyphenidyl. And axial symptoms, it fares most poorly. 50% improvement in axial symptoms with levodopa, only 8% improvement with trihexyphenidyl. And 61% improvement in the total UPDRS and 26%. So you can see the only thing that is actually improving meaningfully is probably the tremor compared to the improvement from levodopa. Whereas axial symptoms, which are a big problem, very disabling problem, freezing, these are balance issues, don't respond to trihexyphenidyl. So when should you consider using this drug? I would I would say that the general answer to whether we should use trihexyphenidyl in PD is no, we do not to use it as a first line drug in any patient. But I personally use it in very exceptional circumstances, such as a juvenile or a very young onset PD with prominent dystonia. In these patients, we may be justified in using it. And this is also seen in the Movement Disorder Society guidelines for the treatment of Parkinson's disease. So they say that for younger patients, they may be an option, may remain clinically useful, but their use should generally be limited to young and cognitively intact patients because of their unfavorable neuropsychiatric profile and the long-term risk of memory impairment. And this is there now, we know from our data, it is also there for young patients. So I never use it, or almost never initiate it. And just like Dr. Subodh said in the beginning, most of my efforts go into reducing it, but there may be an exceptional circumstances where one is supposed to use this. The other two indications that are often brought up are refractory tremor, but for this we have much more safer and effective therapeutics like deep brain stimulation, which for patients with the refractory tremor should be considered for an early DBS rather than putting them on drugs which may cause much more untreatable problems in the future, and extreme financial constraints. But these are the two situations where sometimes one is forced to use these drugs. But I feel that the solutions for them should be in arranging the means for financial support. One should try or in the policy level or at the best efforts that one can put to arrange those for these patients, rather than exposing them to drugs that can land them in much more trouble later. So the only probable situation that I would use it is an exceptionally young patient with prominent dystonia. So my take-home message is that while trihexyphenidyl is very commonly used across our country, I feel that the risks definitely much more outweigh the benefits for a general PD patient, regardless of the presentation, whether tremor is there or not, regardless of the age, whether less than 60 years or not. There may be very exceptional circumstances where one is forced to sort of use it, but except for that, I would suggest that we not use this drug except in exceptional situations. Thank you.
Thank you, Dr. Rupa. And I think the way both the presenters were speaking, I think it is against what the audience perception was. I think, and in the end, I think the scenarios where Dr. Suri suggested that trihexyphenidyl should be used, I think you also in your presentation, you also actually have said that. I think most of you, I think, are referring to the Parkinson mutation related patients. I think the scenario that you are saying, young onset Parkinson disease, lower limb predominant dystonia, I think that fits into the Parkinson phenotype. A lot of time we don't get the genetics done in these patients, but I think that is what is coming up. And the other thing is that even there is a question that patient with tremor, which is not responding to levodopa, and you all say that you should not use trihexyphenidyl. What should be done? Maybe Suvarit can give a rebuttal. I think he doesn't have much. That is what he was saying to refute what Dr. Rupa is saying. But we'll have a poll and see if both of your presentation did change the audience perception. Maybe Suvarit, you can talk a minute.
No, there is no rebuttal. As you can see the first line on the top. I'll let Dr. Rupa Rajan win this debate for the greater good. And again, we both agree on these points, on the points where to use trihexyphenidyl. It should be kept as a reserve drug, mostly in young patients who are cognitively okay and who present with dystonia and who have a lot of tremor and they are not able to tolerate higher doses of levodopa or have high side effect profile for using dopamine agonists. So it can be useful in some patients, so it has to be. We cannot totally take out trihexyphenidyl from the armamentarium. We have to keep it in our list of drugs. But what I'd like to know, or what are the points to explore, what is the impact of cognitive burden in PD patients? Like sometimes there is incongruency between the objective parameters that we are assessing and the subjective well-being of the patient. For example, an elderly patient who is relatively okay cognitively or may have mild cognitive impairment while on trihexyphenidyl and has a tremor, but the tremor is being well controlled with trihexyphenidyl. In those patients, why not to use trihexyphenidyl? I'll not use trihexyphenidyl. I'm not suggesting that we use, but these are some points to explore and maybe some points that need to be studied to let the people know that using trihexyphenidyl may maybe with a lot of side effects that are really impactful in their social well-being. Thank you.
Thank you, Sorit. Dr. Rupa, I think in her presentation showed actual patients' videos and then showed clinical studies and then even showed biopsy reports where, and I think she had diligently said all the issues. But if she wants to add any one more point, maybe we can listen to her. Then we'll have the poll again.
Yes, I think, generally I am glad that we are all on I don't think this is a debate where there is going to be one winner or a loser, because we are all on the same page about it. But I think it's very important to highlight this issue, seeing that how widely used these medications are and how lightly used they are. So I think in medicine, there is never 100%. So never it is going to be that, something is totally not useful, never to be used, or something, it's never going to be that. So there are indications of special situations where one may consider this drug, but I would say that they are the exception, very minority, and this should definitely not be the first drug or among the first drugs that you consider for a patient, PD patient.
Thank you, Dr. Rupa. And I think before having the poll again, I'll say what happens like when general neurologists start the patient on these drugs, and these patients ultimately when they land up with movement specialists, how many of them are able to successfully taper off this trihexyphenidyl in these patients? I think that is one thing we'll discuss out after we have the audience poll. Because I have had patients who from India have gone on a visit for 1 or 2 years to USA or Canada and all. And when the doctors stop the trihexyphenidyl over there, they actually have worsening in their motor symptoms, especially tremor, and they feel very bothersome. And sometimes, like what I feel is our patients are like want a shortcut. So, like if we start levodopa, the control in tremor and all would come about 3 weeks to 3 months. Well, if you start trihexyphenidyl, it's seen within a week. So, a lot of times, I think the reason patients are prescribed trihexyphenidyl early is they want a quick improvement in the tremor, which is most of time the most bothersome. So let's see what people in the audience feel. Have the presenters been able to change their mind or not? And then we'll have.
Sir,
after the poll,
give some opinion. Let us give some opinion, then have the poll. I think
we'll have after that also. We'll have third poll, sir.
Doesn't matter. I think because there are some certain things, isn't it, Sanjay? I think.
Sir, we want your opinion, and then we'll have a final poll after what you all three say.
So many polls are not needed, I think. Yeah.
That is how we are doing it. And then I'll also have Dr. Chaturbhuj remove his epilepsy hat and talk as a general neurologist also like what it is. Sir, if we can, I'm sorry, but if we can just have and see if the audience they have changed their view or not, and then we'll have again all the three of you one by one. Can we have the poll again? Okay. So the classic contraindications to trihexyphenidyl are not there here. Cognition normal, prostate is not there, age is not more than 70. What would the audience feel? Let's see. We'll close it in about 10 seconds. Oh, so despite the talks from the presenters, the audience has not yet convinced. Yeah, the audience still feel more than half of the audience still feel that trihexyphenidyl should be used in patients with Parkinson's disease.
So it
And
may
the
be
main-
because of the way the options were framed. The first option, addition of trihexyphenidyl to levodopa will certainly help in tremor. That's true, probably true, but that's why probably they are selecting that option. But second point is more important, that addition of trihexyphenidyl to levodopa may be helping in tremor, but can lead to more adverse
Exactly.
effects affecting the quality of the life of the patient.
So that is what I think the general neurologists always feel, that they are more, and even I think their point is because the patients want a better control of tremor. I think this leaves good points for Dr. Pal, Dr. Sanjay, and Dr. Neeraj to take and discuss it further. And again, let's see what sense here. So here, this is a different type of controversy. Generally, the presenters fight amongst themselves. It continues here. The presenters are agreeing to a point which the audience is not agreeing. So maybe now this is a good point to chip in our Brahma, Vishnu, and Mahesh one by one, and let's see what they all say. So maybe we start with Dr. Pal, sir.
See, I think the controversy, there is no controversy about this. This is only a guidelines. Okay. Whatever Rupa said, Subhri said are mainly guidelines, and all movement research specialists will be going by that guidelines. And there are 2-3 points. One is that even in Western countries, Rupa must have quoted that big study, there are many people are taking anticholinergic drugs. Okay. And there is a concept is that a tremor predominant will better respond and can be started on anticholinergic. Otherwise, such a big study wouldn't have been showing so much of data. Okay. So still the prevalence of using anticholinergics is there. Second thing, in our country, one more side effect I think no one has pointed out, but one more thing also you should remember, that anticholinergics has potential to cause postural hypotension. Okay, so this also can cause a problem. But the thing is that many people think that the adequate dose, suppose you treat a patient who comes with a tremor predominant Parkinson's disease and you start with only anticholinergic drugs. It is not that it is cheap. So we had done an analysis that if you take 3 tablets of Pacitan or trihexyphenidyl or whatever it is, it's quite costly. It is not. In fact, the levodopa carbidopa with a 1.5 tablets can be better managing the tremor rather than taking 6 tablets of anticholinergic drugs. Okay. So apart from that, I think everything whatever these 2 colleagues have told is correct. It cannot be a first line of treatment in a patient of Parkinson's disease in any age group. Okay. And then there are specific situations where we should encourage, we should try after giving adequate trial of levodopa. Even in dystonia, prominent Parkinson's disease, I think the levodopa is the first choice rather than any other drug. And this should be, yes, I agree with, I think one of you told that once a patient gets the taste of anticholinergic drugs, even if they may be happy with getting hallucinations, but they will restart the anticholinergic drugs. Even if they get demented, they will restart the anticholinergic drugs. So whenever a patient comes first time, if anyone within 2-3 years has a mild forgetfulness, and hallucinations, 99% of the time this patient has been started on anticholinergic drugs. And 99% of time there will be reversal after stopping these medications. So this is my point. Yeah.
Okay, I'll invite Dr. Pandey also to speak about it. But I would like encourage the audience to write their comments in the question and answer session or chat section, because the way the presenters are saying and what the audience are saying is completely different. So in the meantime, till Dr. Sanjay and Dr. Neeraj speak, the people in the audience can write their comments or questions. We'll take them up too. Dr. Sanjay.
No, I think most of the facts have already been shared by Rupa and Subharit and Paul sir. But I would like to emphasize one point, that there was a paper in Brain, I think published 4 or 5 years back, and they have analyzed the cholinergic versus dopaminergic axis, and they were very categorical to say that in Parkinson mutation patient, there is a cholinergic axis, and in those group of patients, maybe anticholinergics may be effective. But the problem is not that. The problem is to stop levodopa to stop anticholinergic in a patient who is already taking that. So if the patient is taking anticholinergic coming after maybe seeing 3-4 consultants, and you are trying to withdraw it, it becomes very difficult. The reason is that there is a rebound tremor, and the moment there is a rebound tremor, the patient is very reluctant to stop it.
Okay.
Like I have a pediatrician here, very eminent pediatrician of the city. He has a Parkinson disease, and he was on 6 tablets of levodopa. The moment I said that I'm going to stop it, and the moment I brought it from 6 to 4, he came next day and said that my tremor is worse. So the question is that there is a rebound tremor phenomena. So you need to be very slow in tapering the anticholinergic drug. And it may take 3 to 4 months before you completely wash it out. But once it is washed out, the patient is very, very convinced that yes, anticholinergic has no role in management of Parkinson disease, and levodopa can control the tremor equally and maybe more effectively. So the challenge is not the new patient, the challenge is old patient. And but we need to take this challenge, and we need to be very slow in our practice. We cannot be just say that no, I'm just going to put you on levodopa and anticholinergic will be stopped from the same day. It will never work. You have to be slow, you have to be gradual, and you have to convince the patient, and most of the patients get convinced in the long term. But definitely when we are starting the treatment, it's very easy because even if a very severe tremor dominant Parkinson disease patient, they respond to levodopa very well. Maybe it takes time, maybe few weeks, maybe a month, but they respond very well, and they do very well in the long term. And I will add one more point before I finish, that Rupa beautifully showed a couple of cases where dyskinesia got worsened by anticholinergics, and this should be emphasized, and that if we are using anticholinergics in the beginning of the treatment, maybe the dyskinesia will come early, and maybe it will be worse. So this should not be encouraged. So these are my viewpoints.
Thank you, Dr. Sanjay. And I think I always put Neeraj in difficult conditions. Like everybody has spoken, and he has to say what. Maybe you can add a few points and maybe summarize, make my work easier. Summarize what I'm saying, and then let us see. I'll take a few questions after, and then we'll see a poll, and let's see what people say now. Okay, Neeraj. Neeraj, please. You are muted.
Am I audible now?
Yes, yes.
Yes, so I think an excellent presentation, Rupa and Subharit as usual, and nice points brought up by Dr. Pal and Dr. Sanjay. I think what a couple of points which Dr. Sanjay highlighted is extremely, important, that it's slow to taper. And one of the reasons why, because while going through, initially I learned that the metabolism of this trihexyphenidyl or anticholinergics, that is hampered in patient with Parkinson's disease. So usually like it goes to, this is something like at the molecular level, what happens, like cytochrome P450 is the enzyme which probably is the one which 40% reduction in the level in PDF is well shown in quite a few studies. So this is something which basically hampers the metabolism. So many times the effect keeps long. It keeps on even if you are trying to taper off the drug, and then the patients had developed those craving type of things. And the another point, which practical point, which I had noticed, like probably Pacitan, as it slows down the gut, constipation is something which is, as Rupa has nicely showed. So it does affect the levodopa metabolism. It slows down the absorption. So this is something which probably will be one of the factors which practicality which can be used to, as a point favoring not why not to use again Pacitan if we are having a better drug, or maybe a drug which probably is better acting on most of the motor and other features of Parkinson's disease. And third point I wanted to highlight is, as Dr. Pandey told, is the levodopa does act on tremor. So this is, many times I tell my patients that levodopa usually acts better on bradykinesia and rigidity when you start. And it's like, suppose you are just loosening the nuts of the chair. So it's kind of that the rigidity is gone, bradykinesia is something which is reduced, and then the tremors becomes more obvious. So that is something which probably will be taken care of as you increase the dose, or as the dose or the pharmacology of the levodopa optimizes itself with time. So I think the fact that Pacitan acts better for tremor, I mean, personally, I don't feel that. I still feel levodopa does well. And with many of the studies, and lately the LEAP study coming into picture, I think probably levodopa is the drug which probably we should choose. And again, I must congratulate Rupa for that slide which she put, where she had nicely shown that retrospectively, that the pathology slide. So that has very clearly shown that this cholinergic deficiency, which is being created by the use of anticholinergics, and that pathology is pretty much the Alzheimer's like pathology is something which is found in PD as the disease progresses. So what this anticholinergic is doing, it is just one of the modifying factors which probably is easier to get hold of, because most of these patients in Parkinson, they will go on and develop dementias or cognitive decline. So that is the fate of the disease. With duration, I think 15 years, 20 years, maybe 70-80% will develop this cognitive decline. So by putting them more at risk of cognitive decline, I'm not sure if we are doing any good to them, because what these anticholinergics will do with them may just hasten the process. So probably this is something which already the speakers and the presenters, they have very nicely shown. So I will just like to add a small practical point, that this is one of the factors which can be modified. Like most of the other factors of cognitive decline cannot be modified. So by not giving our patients anticholinergic drugs probably is something which will help them help us to delay the cognitive decline in them. Because most of these patients, as Rupa has said, that they have anticholinergic burden, whether it is through antidepressants, antipsychotics, serological drugs, or several other drugs. So although it is not only trihexyphenidyl or anticholinergics prescribed for PD, which is important, because already they may be having a burden of other drugs which may be adding to the anticholinergic burden. So again, we will be adding something extra which probably may be done away with, especially with levodopa doing so well for most of the symptoms.
Thank you, Neil. I think one of the questions in the Q&A section is about this, that people always believe that THP is the main drug for control of tremor, because the question is that what is the alternative of THP in tremor predominant PD if the side effects of THP are predominant? So I think that is the main challenge. I think from MBBS days, I think we are taught that trihexyphenidyl is for treatment of tremor and levodopa is for treatment of bradykinesia. And that, I think, that continues. So I think again, the panelists are like have to answer, how do we control this? Neeraj?
And just actually, what you said is very correct. Like in MBBS days, we used to read this, but probably the point where was it was just painted. I mean, the straight fact was that trihexyphenidyl acts only on tremor.
Exactly.
Acts only on tremor. Probably the same, that point has been modified, that trihexyphenidyl acts better on tremor. I mean, that is what I understand after I have gone through those 15 years of my experience from MBBS to a movement disorder enthusiast. I understood that. So it's not that trihexyphenidyl is better, but probably the main effect of trihexyphenidyl we are seeing is probably more on tremor than anything else.
Exactly. So what are the options for treating tremor in patient Parkinson's disease? I think once the audience is convinced about what are the options and how we can control tremor in PD in a better way without using THP, I think we will be able to change their minds.
You can give, I think, if levodopa dose increase is not being tolerated, you can add dopamine agonist. Sometimes it helps. Okay. Otherwise, mirtazapine is a good drug which can control the tremor as well as other Parkinson features plus depression. Third thing is that obviously the other things like clonazepam and beta blocker also may have a role, but I have never used. I don't use it, but we have seen that sometimes it helps. Okay, and another thing has to be pointed out that many of these patients of tremor predominant PD, or they have rest as well as postural tremor. Okay, so the postural component has to be dissected out from the rest component. Now, how much is the role of anticholinergic drugs on postural tremor? I do not know whether is there any role or not. And another thing is that what happens is that when levodopa improves the rigidity bradykinesia also. Okay, suppose in a patient who in the right hand has tremor, rigidity, bradykinesia. If the tremor, the rigidity and bradykinesia is almost becomes 0 from 3, okay, the tremor amplitude seems to be increased because of the excessive excursion, and amplitude becomes more. What happens in anticholinergic drugs, my theory is that it helps in the tremor, but not in much of the rigidity bradykinesia. So rigidity bradykinesia remains in the grade 2 level. So the amplitude of the tremor seems as if it is low. So many patients, what happens that immediately after taking levodopa, after some time they say that I'm having severe tremor. Okay. Some patients say that after taking the tablet, I'm started having tremor. So some say that you increase the early, you take a little early because probably the offset had already started. Or sometimes it can be because too much action on the rigidity bradykinesia helps the tremulous axis and the limbs to become more violent. Okay.
Yeah. Any other points from anyone?
So I
Sorry.
wanted to take this opportunity to ask, is there any, have you used zonisamide like sometimes?
Yeah. We have used, yeah. But today only I found one patient had a kidney stone. So it causes kidney stones definitely, and all patients I first do a ultrasound. If there is no stones, no history of gallstones also, then only I start, and plenty of water. Advice has to be given. Within a year, many patients develop stones.
But is it helpful? Like, how helpful is zonisamide?
Topiramide, zonisamide, some are all helpful actually. Though not
in tremor, but in Parkinson's disease related tremor.
Zonisamide definitely can be tried. Okay.
Yes, zonisamide. So we have also have a randomized trial, a small randomized trial of zonisamide for tremor, refractory tremor in PD. So I would say that about 30% of patients responded, and some of them even after the so it's not that everyone will respond, but it is one of the add-ons. So I think as Palsar said, all these drugs, levodopa, dopamine agonists, even amantadine, all these are options. And if not, we can try things like zonisamide. And if all of these 4 drugs don't work, then they are probably candidates for considering an early DPS.
And sometimes
Dr. Sanjay wanted to add.
On a lighter note, one good thing acetane or anticholinergic drug does that it helps us in making early diagnosis of MSA and PSP.
Yeah.
So if the patient is given anticholinergic, and if they develop bladder symptom, maybe you can start thinking of MSA, and if they develop dementia, you may start thinking of PSP. So this is very common in a clinical setting, and then you struggle withdrawing the drug, and patient go on adding the symptom, and making the diagnosis becomes very easy, maybe after 1 year or maybe within 1 year time. So
yeah, but it makes tricky also, things tricky also, like whether it.
Another point.
Neera.
The last point for tremor, actually, sometimes patient may be having significant tremor and less of other symptoms. So I think botulinum toxin injection is something which can be tried in these patients, and many patients do respond well, especially EMG guided. If you give that Botox, especially, so that botulinum toxin does help in these tremors too.
Okay, there are a few questions not related to Parkinson. I'll take them at the end. Maybe if Dr. Chaturbhuj and Dr. Sanjay are there and want to pitch in, I think Dr. Chaturbhuj was a bit busy, but if he is there, maybe I'll tell him to remove his epilepsy specialist hat and talk as a general neurologist and give a comment what he feels. Is he there or no? Dr. Sanjay?
Yes.
Sanjay Prakash, like among the... I think Sanjay or Chaturbhuj, if you want to add in.
Sanjay is hiding, I think.
Sanjay is hiding. Okay. I think then we can have the poll again, and then we'll take...
Swam, I just want to ask maybe any of the panelists or anyone, anyone has any experience in looking into the fact that those who have re-emergent tremor, they respond better to anticholinergic drugs or they respond better to dopaminergic drugs? I think it's dopaminergic drugs. So re-emergent tremor in the patient, I think, has a much better response to dopaminergic drugs.
I agree to that. But I think a good point to work up and let us pull up patient and check it together.
And another thing, if you take Sanjay, maybe you have more experience on this. If you take a patient with PD and you give only anticholinergic drugs for tremor, mainly for tremor, the tremor control. See, we see often that if the rest tremor, even if you treat with levodopa, it controls. But as soon as the patient becomes anxious, it restarts. Okay. Does the same thing happen in a patient who has been controlled with anticholinergic drugs rather than dopaminergic drugs? Anyone can tell anything? So the re-emergence of the tremor as soon as there is some anxiety, okay, happens often we see in a levodopa controlled tremor. Even in the very good on state, as soon as you tell them to count backwards, the things immediately the hands start shaking. But when a person is controlled well with anticholinergic drugs, suppose for instance, only with anticholinergic drugs, does the same phenomena occur?
Yeah, So this is a very valid question, and this is the reason patient don't want to stop it.
Yeah, I have seen. Yeah.
Yes, because the moment they stop it, there is a re-emergent tremor, and then they continue taking it, thinking that if I don't take it, my tremor will never disappear.
Yeah.
So we need to counsel them that, look, you have to wait, and we have to convince them. That is a difficult task, but in majority of the patient, we can do that.
No, I agree to Professor Pal. Like in my clinical practice, those who are anxious and those who are having a lot of tremor, they are likely to be on trihexyphenidyl. So
I'm not very sure of. I feel that in PD, despite any medication, even despite DBS, sometimes when patients are anxious, tremor can come back.
That is different. Yeah. But it's worth studying if
Yes,
somebody
sir.
you
I
see
don't think there is any data.
patients who are only taking anticholinergics and only taking levodopa. Before stopping these anticholinergic drugs, you can see what is the effect on those. Yeah.
So what would that tremor be called? Enhanced physiologic tremor or enhanced tremor of PD, which is worsening because of anxiety? Because they say that organic tremors, like what? I should not use the word organic or non-organic, but their distractibility or change inconsistency should not be there. So PD is exception, where it at rest it is there or action.
So any sympathetic drive, any stress, anxiety, all these things are sympathetic drive. Any sympathetic drive will increase mainly the amplitude of the tremor. Okay, any condition, any type of tremor, I think so. And another thing is that when you have another thing, you can always advise to take less coffee and tea because they definitely worsen the tremor even in PD patients.
So the clonazepam and mirtazapine, you are saying, is it reducing tremor?
Clonazepam helps, mirtazapine helps. Okay.
In reducing the anxiety component, which leads to reduction.
Clonazepam can be given for the reducing anxiety as well as also tremor. Because in the treatment of tremor itself, though these patients are more having postural tremor plus rest tremor. Because PD, 40% of the patients, those who have rest tremor will have postural tremor also. Okay. Sometimes the patient may not differentiate between a rest tremor and the postural tremor. Because even in the only classical rest tremor, actually the moment they start doing some little action fidgety movement with the holding the clothes, the tremor will disappear in them. Is only rest tremor and no postural tremor in those, no action tremor in those patients. And another thing no one has pointed out, but another problem occurs when a patient develops tremor at the head, neck, limb, tongue, chin. In those patients, I don't know which is better, whether the dopaminergic drugs are better or the anticholinergic drugs are better in a patient's PD. It is very difficult to treat sometimes the head tremor and chin tremor. Patients have tongue tremor.
But I have seen chin tremor, tongue tremor respond
all
well.
disappear. Yeah, levodopa they respond here. Yeah.
So I think the controversy is that in practice we see that trihexyphenidyl use is very, very, very common, but the experts say that it should not be used. So let's see. We
see another thing just to say that in our practice, everyone, if after giving adequate dopaminergic drugs, if the tremor doesn't come down and there is no urgent contraindications, we can try anticholinergic drugs in them in a small fashion if there is no, because a very, very severe tremor pending a thalamotomy or a deep brain stimulation. Okay, 99% will not be able to afford that. They want to do something for my tremor. I am taking 600 million of levo, 800 million of levodopa, carbidopa, 1.5, 4.5 million of pramipexole. What is left? Nothing else is left. So what will you do with these patients? Just try little clonazepam and then you have to try. So at a certain stage, sometimes we have to explaining properly the side effects in a controlled fashion. You may have to try anticholinergic drugs, but this is left up to.
So the framing of question to have the in the poll was like a big headache for me, and I and Chatur were trying to change it. What should be kept? But again, so we kept this. Let's see what now the audience say. Can we have the poll again? Have we been able to change the views of the audience?
Audience has reduced by 30% now. So I do not know the participants.
That is generally expected. So that is generally expected. But
so which group has gone away, we do not know. So
let's see.
Come on, audience. I want Dr. Rupa Rajan to win. Come on.
So again, the question is the same. So no contraindications to trexafinidine, but as the experts are saying, you all should try to avoid it because in the long term, it is going to cause problems. And the tremors which people feel that it is controlled only by trexafinidine, it should be controlled even with levodopa alone also. So let's see what you all say now. Can we end it in 5 seconds and see what the audience says now? And then there are a few non-Parkinson-related questions that we'll take up. Can we see the results? Oh, very good. So I think now half of the participants are saying that they would like to avoid trexafinidine. I think, but still 40% are in favor.
It took a team effort.
Yeah, but still it is like half, 60-40. I think the ones who are not sure got into, I will not use, I think, and some 20% of the ones who wanted to use now have shifted. I think that is a good.
Sir, you managed to change the direction of the tide.
Yeah.
That we can know if Rupa, Dr. Pal, or Dr. Sanjay does another case control or a cohort study 5 years down the line, like did this evening change the practice or not? There are a few questions. They are not related to Parkinson's, but I'll take up. I think Dr. Mrinal Kanti's comment I liked. Mrinal Kanti Rai from Bengal. She says every case should be individualized. Here, the clinical acumen and judgment that count a lot, taking into the consideration about the history and the responsiveness. I think that is a fair comment from a very senior consultant. There are two questions about. One is that psychiatrists routinely prescribe trihexyphenidyl along with antipsychotics for a long period of time to presumably prevent drug-induced Parkinsonism. Again, this is one issue which needs address. Thing. But when such treatments are given, patient develop dyskinesias. How can you differentiate it if it is trihexyphenidyl induced or tardive dyskinesia due to antipsychotic? So there is this belief that if patients are on antipsychotic, if you give trihexyphenidyl, it will prevent drug-induced Parkinsonism. So what are the views of panels here?
I think, sir, like most often they use trihexyphenidyl from the beginning. They prescribe antipsychotic to prevent the drug-induced dystonia, the acute dystonia that comes with the use of the antipsychotic, not to prevent the Parkinsonism later on. So
that is what we believe, but the psychiatrists often think that drug-induced Parkinson, all drugs, drug-induced extrapyramidal symptoms, if we give trihexyphenidyl, it will be taken care of, which is actually not correct. So how do we?
Yeah, I think there are some AN guidelines on tardive syndromes. It is very clear in stating from the available evidence that there is no role of using these drugs upfront to prevent a tardive syndrome or Parkinsonism. So as Dr. Suborit said, if there is an acute dystonia, then you can use it to treat it. If there is a drug-induced Parkinsonism, this may be a drug to treat it for a short while. But using it, in fact, only increases the chance of developing tardive dyskinesias and dystonias. in combination if you start along with it. So actually, that is a practice that again probably needs to be changed. And once it develops, I saw the question that whether we'll call it trihexyphenidyl induced or tardive. That is very difficult to answer. But most often, if it has occurred in the setting of exposure to an antipsychotic for more than 12 weeks, we will call it a tardive syndrome. But if it is, but it may sometimes be trihexyphenidyl related also. But that there's no role of prophylactic use of these drugs.
I think
This is
so.
my
All
understanding.
so all the ones in the audience, I think they have psychiatrist friends. They all can like tell them that there's no valid point to start trihexyphenidyl directly. And another similar question on the same line is that in cases of chronic schizophrenia, giving trihexyphenidyl becomes a necessity with antipsychotics. We find tremors after months and years of usage. So what should we use? With low dopa, the psychiatric features may exacerbate. How do you differentiate tremors of antipsychotics and that because of onset of PD? So again, I think the same questions. I think there are different features. I think a best way would be to refer the patient, and this is probably by a psychiatrist, refer the patient to a neurologist, let them evaluate, and there are ways by which this can be done. I think rather than discussing this question further.
If you have the option of a the product scan and all, you can try. If it is a drug-induced P-synaptic part, will be normal, the classical cases, and if it is a post, so PD, it will be abnormal. Yeah.
Correct. And there's
But
one last
by and large, most of the time, the Parkinsonism and drug-induced Parkinsonism, it is more of a rigid bradycardia rather than tremor. Yeah.
Right. So one just question has come in that what drug for treatment of drug-induced tremor, I think. First is that stop that offending drug and then observe, give time and assess how it is happening.
Beta blocker works sometime in drug-induced tremor because many of them are peripheral tremor and many of them are very similar to enhanced physiological tremor.
Right.
So drug-induced tremor, beta blockers may work sometimes.
So like akathisia, beta blocker works, even tremors also it can work. I think we have had a fair discussion. Dr. Pal had told me that I have another work at 9:30. You finish off before that. So 10 minutes before we will have been able to wrap it up, I think. I thank, there are no more audience questions I can see. I think I'll thank first Dr. Suvarit for mainly, I think, taking up a losing cause and fighting it up. I think the reason was more to make people aware that trihexyphenidyl is not to be used, though it is being used in common. Then Dr. Rupa for very nicely she took it step by step and how from patient videos to clinical evidence to pathology evidence she took up. And our Brahma, Vishnu and Mahesh, Dr. Pal, Dr. Sanjay Pandey and Dr. Neeraj for further putting the hammer on the nail to, I think after their comments only the audience actually changed their views, I think. So thank you for enlightening everyone about not using trihexyphenidyl and stopping this controversy and giving a consensus which is already actually there in the published thing but not into practice. I'll end here if there are no other comments, and I'll if anybody has a comment I can take it there.
Thank you. This is an excellent discussion. Yeah. I think somebody should write up a paper for AOMD review article.
Yeah.
I can take the opportunity to request the panelists to do it. Not the panelists.
Rupa and
Suvarit will write as a controversy paper.
Controversies kar do
one
paper.
and for and against, like, or maybe a review.
That will be a nice
Or
paper.
guidelines of using anticholinergic drugs for Parkinson's disease in
quick paper would be very good idea.
in India.
We can write a comment on that basically.
Practice and parameters of use or something like that.
Yes,
I think Suvarit and Rupa can write a review and Dr. Sanjay can write a comment or related to editor on it or editorial. Great. I think that would be great.
Yeah.
Thank you everyone. I think
you.
have a good night and that I don't have anything else to say. Yeah, but I have to thank the INTAS for like taking up this activity, this monthly activities of doing this controversies to consensus program in neurology. I think that's all. Thank you.
Bye.
Thank
Good
you.
night. Good night, everyone.
Good night.